Good morning, everyone. This time we will learn about the radiology of common disease of bone. First, we will learn about the traumatic lesions. Routine X-ray examinations. First, it shows presence or absence of the fracture, and it helps in the reduction of fracture or dislocation under television fluoroscopy guidance. Here is films of traumatic lesions, and we could see in the proximal part of the radius, the cortex discontinuity, and we could see the fragments. And here is the lateral view, and here we could see the dislocation of the shoulder joint. The radiography of the fracture. Fracture of the long bone. Fracture is defined as a break across the bone with discontinuity of the cortex and interruption of the bony tuberculations. It includes discontinuity of the cortex or interruption of the bony tuberculations. The X-ray appearance. Fracture line is a defined definite radiologic feature of a fracture. It appears radiologically as a translucent line between the fracture fragments and shows a irregular and sharp marking. So in the long bone, we could find the translucent line in between the fracture fragments, and the fracture line is irregular and sharp marking. Here is a films of fracture of the tibia, and in the distal part of the tibia, we could find the fine line near marking translucent line in it, and the cortex is discontinued. So we call it fracture of the tibia. But in an infection of the fracture fragments, the translucent line may not be seen instead of a dense line. Here is the fracture of the spine, and we could find that the vertebrae become wedge-shaped because of the impacting, because compressing. So that's the fracture in the vertebrae. For compression, it becomes wedge-shaped, and in the vertebrae, here is the translucent line, but in the mid part of the vertebrae, we could find the dense line. Here is the dense line in it because compression. So this is the fracture of the spine. Maybe we could not find the translucent line in it. Instead, we could find the dense line. Here is the X-ray. The vertebrae become wedge-shaped. Fracture classification by radiology. According to the direction and shape of the fracture line, it may be oblique, spiral, longitudinal, Y-shape. A community fracture denotes a fracture with more than two fragments. Here is the fracture of the skull, and we could see that here is the translucent line, and the translucent line is irregular and sharp marking. Here is the translucent line. Here is the translucent line. Translucent line in the metacarpal. And here is spiral spiral in the distal part of the tibia. And fracture of the calcaneus, and we could see the irregular translucent line. Here is the longitudinal translucent line here. So we could make a diagnosis of fracture of the calcaneus, and here is the fracture of the radius, and we could see the fracture line or translucent line in it. And here is the fracture line, so we call it fracture of the radius. Here is the fracture of the in the proximal part of the tibia, and here is the cumulative fracture because the in the lesions we could find more than more than two fragments in it, so we call it cumulative fracture. Here is the three dimensional reconstruction of the knee. We could see the fracture fragments more clearly. And here is the fracture of the patella. And in this view, the patella we could not see so clear. It seems fracture line in it, but we could not make sure that the translucent line is in the patella or in the distal part of the femur. So we could find the lesions in the lateral view. And in the lateral view, we could see that the translucent line is in the patella and in the mid part of the patella. So, and the soft tissue around it, the soft tissue is swelling. So we could make a diagnosis fracture of the patella. And this is the fracture of the patella and after internal fixation. Here is the fracture of the femur neck. And here this view is internal fixation after internal fixation of the fracture of the femur neck. Also, we could find the cumulative fracture in the distal part of the femur. And the fragments of the fracture displaced. Here is a fracture of the surgical neck, and we could see the head of the humerus displaced. And here is the fracture, the films of fracture of the fifth metacarpal neck. Here, it's a fracture. According to the extent of the fracture, it includes complete fracture and incomplete fracture. In the complete fracture, it means entire width of the bone, and in the incomplete fracture, it shows only one part of the cortex is buccal or broken. It is called green stick fracture. Usually occurs in the children. And here is the complete fracture, and we could find the entire width of the bone, the fracture line here. So we call it complete fracture. And here is incomplete fracture. We could see that the cortex is just buccal. We call it green stick fracture. Here the cortex is buccal. We could not find the fine line near marking of the fracture line in the green stiff fracture. So this is incomplete fracture. Pathologic fracture. Fracture occurs in a diseased bone. So you could know, and you know that first the bone is diseased, and then the fracture happened in the diseased bone. So we call it pathologic fracture, such as in osteomyelitis, tumors, and some other bone disease. This is the bone disease in the humerus, in the mid part of the humerus. And first this is the diseased bone, and then maybe the patient had a trauma history, so the fracture will happen easily. So we call it pathologic fracture. In the bone cysts, the bone cysts are generally discovered because of a fracture due to an insignificant trauma or incidentally after X-ray, an X-ray examination for other reasons. So maybe the patient had bone disease, but he or she did not know. But when he or she had insignificant trauma, the bone will happen the fracture easily. Then he he or she will take the X-ray examination, and then the bone cyst may be found. So this is the pathologic fracture. Here is the pathologic fracture, and we could see that in this part of the bone, the density is decreased. The density is decreased, so we know that this is the diseased bone, and then the fracture happened. So we call it pathologic fracture. The position of the opposition of fracture. The distal fragment may be displaced either anteroposteriorly or lateromedially. The fragments may be overlapped, impacted, separated, or rotated. There may be angulation between the fragments. Once a fracture is identified, one must pay attention to the position of the distal fragment in relation to proximal fragment. So when the fracture happen, we could pay attention in the position of the opposition fracture. Here is the films of the fracture in the distal part of the femur, and we could see that the distal fragment. Here is a distal fragment displays the fragments. Here the fragments. The opposite part of the fragments overlap. So when you make a diagnosis of fracture, and you may describe the distal fragments displaced and the fragments overlap, you could describe these details. Fracture of the spine. The affected vertebrae body becomes wedge-shaped for compression, and the translucent line may be dense line. So this is the fracture of the spine. It occurs most in the flexible portion of the vertebral column, such as lower thoracic and upper lumbar region. The X-ray appearance. 1. The affected vertebrate body becomes wedge-shaped due to compression. 2. The translucent fracture line may be hardly visible and often replaced by a dense line as a result of impaction of the fragments. 3. The intervertebral disc space may be narrowed slightly, but usually well preserved. This fracture is quite different from that of tuberculosis of the spine. And then we will learn about the tuberculosis of the spine. This is the fracture of the spine. This is the actual view of the CT scan. And CT gives a more accurate evaluation of vertebral burst fracture than plain radiology and films because it shows the number of the fragments. It shows the number of the fragments as well as the degree of their retropulsion into the spinal, the fragments into the spinal canal, and their relationship to the spinal cord. In the actual view of the CT, we could find the fragments more clearly than the X-ray, and we could find that the fragments retropulsion into the spinal cord, and the fragments, the relationship of the fragments with spinal cord. So the fracture of the spine, we should take the CT exam. If the fracture is burst fracture, we should take CT exam because we must find there are any fragments retropulsion into the spinal canal. This is very important. These features are of primary importance when treatment is considered. Special fracture in children. 1. Separation of the epiphysis. 2. Green stick fracture. These two fractures just happen in the children. So we will learn about it. In the separation of epiphysis, increase of the width of the epiphyseal plate, epiphysis and metaphysis may be displaced. Green stick fracture. One part of the cortex is buckled or broken because the bone of the in the children is soft, so maybe the cortex not broken entirely. Separation of the epiphysis. Here is the epiphysis, and the epiphysis displays. So we make a diagnosis of separation of epiphysis. How do you know that the epiphysis is displaced? So we could draw a line across the humerus and the ulna. And in the normal side, the epiphysis is in the line. But if the epiphysis is out of the line, we could make a diagnosis of separation of epiphysis. In the lateral view is the same, and we could draw a line across the ulna and in the normal side, the epiphysis is in the line, but in the lesion side, the epiphysis is out of the line, so we could make a diagnosis of separation of epiphysis. Separation of the epiphysis. Here is the epiphyseal line. The epiphyseal plate. Here is the epiphyseal plate. In this view, we could not find any lesions in it, but in the lateral view, we could see that the width of the epiphyseal plate. Here is the epiphyseal plate. The width is increased. The width is increased. The width is increased, and the epiphysis. The epiphysis. Here is the epiphysis. This is the metaphysis. They may be displaced. They may be displaced. So we call it separation of epiphysis. And after external fixation, the position is returned right. The green stick fracture. Here we could find that the cortex is buccal. Here is the cortex. Here is the cortex. The cortex is buccal. So we call it green stick fracture. Here is the cortex. The cortex is continuity, but it's buccal. The cortex is continuity, but it's buccal. So we call it green stick fracture. Here is this view. We also could find the cortex, buccal cortex, and this is the lateral view. We also could find the cortex buccal, but it's continuity, so we call it green stick fracture. Illustrative cases. One is Colles fracture. The fracture line is within 2.5 centimeter from the articular end of the radius. So this fracture we call it Colles fracture. The distal fragment is displaced dorsally and radially, and is often associated with fracture of the styloid process of the ulna and separation of the radial ulnar joint. We'll see some cases. Colles fracture. Here is the distal part of the radius, and the cortex is continuity. And the distal, here is the distal fragment. The distal fragment displays and dorsally and radially. Here is the radially. This is the dorsally. So we call it Colles fracture, and the fracture line is within 2.5 from the articular end of the radius. From here to the fracture line, it is within 2.5 centimeter. 2.5 centimeter. In this, we call it Colles fracture, and the displaces dorsally and radially. After external fixation, it become the displace become normal. The displaced part of the fragments become normal. Here is the external fixation. Here is the external fixation, and the fragments displaced become normal. Here is the call it fracture, and we could see in the lateral view the cortex, the cortex discontinuity, and here is the distal part, of a fragment, the distal part fragment, and it displays dorsally. It displays dorsally, and here is the distal part. Here is the distal part of the fracture, and it displays dorsally. Here is the radially, displays radially and dorsally. And the fracture line is within 2.5 centimeter, within 2.5 centimeter. So we call it fracture. Supracondylar fracture of the humerus is commonly seen in children. The fracture line may pass at a variable distance from the epiphyseal line. The distal fragment may be displaced posteriorly and anteriorly with associated medial and lateral displacement. Here is a film of supracondylar fracture of humerus, and we could see that the distal part, uh, distal part of the fragment may be displaced, enter. Here is displaced anteriorly, and this is the lateral view. Or we may see this in this view. In this view, the fragments displays posteriorly. So we call it supracondylar fracture of the humerus. This is the elbow joint of a child. It commonly happens in the child. Here is the translucent line. Here is the translucent line, and here is the translucent line. This is a incomplete fracture because the fracture line is not entire width. It's not entire width of the bone in the bone, so we call it incomplete fracture. This is the fracture line, and this is the fracture line, but not entire width. So here, this is the supracondylar fracture of the humerus, and it's an incomplete fracture. The fracture of the neck of the femur. This injury is commonly happen in the elderly patient. The fracture of the neck of femur. Here we could see the cortex is discontinued, and the distal part. Here is the distal part displaced proximally. So here is the fracture of the neck of femur. And here is the after joint replacement. And we could also find that the other side of the femur, there's translucent line in it. So then it also did the joint replacement. So this is the fracture of the neck of the femur. Healing of a fracture. Healing process is accomplished through the organization of a hematoma and ingrowth of granulation tissue and the site of fracture. Healing takes place usually 2 or 3 days after injury in the case of an uncomplicated fracture. This is the complete complete fracture. And after 30 days, we could see that here is the proliferation reaction. Proliferation reaction. Just outside the cortex, here is the proliferation reaction, and we could find the currents in it. Then 20 days 20 days later, that the new bone form and deposited between the ends of the bone, and finally the bone becomes a firm bone union. Finally, the bone's union. And uh, in these films, just 30 days after, and the fracture line become blue, but the fracture line remains visible. The fracture the fracture line will remain visible but blue. But 20 days after, we could see the new bone form. The new bone form just in the uh, deposited between the ends of the the fracture fragments, and then it will become firm bone union. So this is the feeling of a fracture. The speed of of union is variable and related to age of patient, size and type of fracture, status of nutrition, and available proper treatment. Average time for union of a fracture in uncomplicated case usually takes about 8 to 10 weeks. Effects in bone union. Delay union. Radiologically, there is minimal or delayed callus formation. If the callus formation delay, the union will delay. Fracture line remains visible for a long time than expected, but there is no sclerotic change at bone ends. At non-union, radiologically, the fracture line remains visible throughout the course with separated fragments. The bone ends become rounded and dense. Sclerosis develops, and pseudoarthritis arthrosis may be produced. Dislocation. The changes of the location of the opposite articular capitulum of joint. It means the loss of continuity at the joint. It may be complete or incomplete. Here is dislocation, and we could see the head of the humerus displaced. This is normal. Here is not normal. This is the joint joint the joint space. Here is the joint space, and here you could see that the head of the humerus displaced. So this is its location. And here is the elbow joint, and here is the normal one. Here is the normal one, and we could see that the opposite bone articular it's normal, and this displays at the joint, so we call it this location. Here is the hip joint, and the head of the femur displays proximally. Here is the normal one. Here is the normal one. This is the joint space. So we could make a diagnosis of this location of the hip joint. Then we will learn about the inflammatory disease of bone and joint. First, osteomyelitis. The pathogenic organism is Staphylococcus aureus, pneumococci, hemolytic uh, streptococcus. This is the pathogenic organism. The cause of the osteomyelitis may be wound, compound fracture, local infection, or generalized infection. The way is direct extension from neighboring infected soft tissue, infected joint, and through the penetrating wound or compound fractures, and hematogenous infection being the most common types. And the X-ray appearance. In the early stage, subtle changes in the soft tissue may appear within the first days. One, focal deep soft tissue swelling is related to the vascular changes and edema occurring within the bone. Subsequently, muscle swelling and obliteration of soft tissue planes occur. 3. Axial abscess formation in the soft tissue is a later new phenomenon that relates to violation of the cortex by infection. Here is in the early stage of the osteomyelitis. We will see in the films, and in the early stage we could find here is the soft tissue swelling, and the bone we could not find any we could not find any lesions in it. This is in the early stage. Just first, the soft tissue swelling may be found first. And the outstanding features of acute osteomyelitis are manifested by extensive bone destruction with marked periobsteal reaction, but little reparative changes. This is the acute osteomyelitis. First, we will find the soft tissue surrounding. Soft tissue surrounding is swelling. And osteoporosis, here osteoporosis. In the distal part of the femur. Here is the periobsteal reaction, proliferation. So this is the early stage of the acute osteomyelitis. Just find we could find the soft tissue swelling and osteoporosis and periobsteal reaction. Here is the periobsteal reaction. In the later stage, the bone changes become evident 2 weeks later after the onset of the disease. And after 2 weeks, we could find the lesions in the bones clearly. Discrete and motor areas of the bone destruction first appear in the metaphysics of the long bone. And two, the small lytic areas become coalesce to form a large area of destruction with ill-defined margin. 3. The cortex is destroyed. Subsequently, within a short time, there is marked perovskite reaction, giving a lace-like appearance along the shaft. That cortical bone may be separated to form sequestrum. Osteomyelitis has a great tendency to become chronic if it is not properly treated. This is the acute myelitis. If the acute myelitis is not will become the chronic. In these films, here is the osteoporosis or bone. Here is the bone destruction. Dis, discrete and motor areas of bone destruction. Here is the motor area of destruction first appear in the bone. And when it become chronic, this become chronic, we could see that here is the bone destruction and periosteal reaction. Here is periosteal reaction. Sequestration is in the destruction, the bone destruction. In the bone destruction, there is high density uh, bone, so we call it sequestration. And soft tissue swelling also we could see. In the chronic stage, there is marked bone proliferation, and there is a striking different radiologic appearance from that to acute stage. The X-ray appearance of the chronic stage. 1. Bone proliferation and increase of density. Thicken and irregular cortex. Bone destruction, and large piece of sequestration in the bone cavity. Here is the chronic osteomyelitis, and we could see bone. Here is this is the cortex, and outside the cortex we could find the bone proliferation, just lace line. And in the bone we could find here is the bone destruction. Here is the bone destruction, and thicken of an irregular cortex. Thicken and irregular cortex. And here is the cortex, thicken and irregular. So here is the destruction, the bone destruction. So we call it chronic osteomyelitis. Here is another patient, and in the chronic osteomyelitis, we may find bone destruction. Here is the bone destruction in it, and here this is the fracture, pathologic fracture. Here is the pathologic fracture, and in the destruction, the bone destruction here, bone destruction, and in the center, we could find the sequestration here, the sequestration, because the sequestration is just happen in the destruction, the bone destruction, in the bone destruction, and the bone proliferation here, proliferation. Just outside the cortex, here is the cortex. This is the bone proliferation. So this is the chronic osteomyelitis. And here is another patient. We could see thickened and irregular cortex. Here, this is the cortex. Here is the cortex. It's irregular. The cortex is irregular and thickened. It's the irregular and thickened. And the bone proliferation. The bone proliferation. This is the chronic osteomyelitis. And this is another cases, and we could find that the cortex is thickened. The cortex is thickened and irregular. So high density in it. So we call it osteomyelitis. Chronic osteomyelitis. Chronic osteomyelitis. Here is the bone proliferation. Here is the bone proliferation, and here is the bone destruction, and thickened and irregular cortex. So we call it chronic osteomyelitis. CT can identify the inflammation and abscess in the soft tissue or in the marrow. Little destruction of the bone and small circumcision not suspected from conventional radiographies. Pyogenic arthritis. The infecting organism affected the joint by homogeneous spread of infection. Spread from a contiguous source of infection or direct implantation. Clinic manifestation. Systemic symptom, fever and chills. Local symptom, pain, tenderness, redness, heat, and soft tissue swelling of the involved joint. X-ray appearance. In the early stage, the soft tissue density around the joint increase. That's the joint swelling. The facial planes or bursal fat pads displays. That means the soft tissue swelling. The inflammatory infusion may lead to an increase in the width of the joint space. Here is a pyogenic arthritis. Soft tissue. Here is the soft tissue. Outside the joint is swelling. Density is increased. The density increased. The width of the joint space increased. Here is the joint space is increased. So this is the pyogenic arthritis. That's the arthritis happen in the joint. Both affecting the soft tissue and the bone. Here we also find the bone destruction in it. So this is the pyogenic arthritis. This is the CT scan. Is the actual view, and we could see that the bone here is the bone density, bone destruction. We could find that the bony tissue is destroyed, and the pathologic tissue instead. This is the bone destroyed, and the soft tissue. here is the soft tissue outside. Around the joint is swelling. Here is the pyogenic arthritis. In the middle stage, the destruction of the articular cartilage and narrowing of the joint space occurred first at point of the maximum weight bearing of stress, and the bone changes 2 weeks later. Pyogenic arthritis. Here, the left knee, we could find that the joint space narrow. The joint space narrow and bone destruction. This shows the destruction of the articular cartilage. Because the articular cartilage is invisible in the X-ray, so we could not see, but we could just find the the joint space narrow. And soft tissue density. Here is the soft tissue density increase and swelling. Yeah, this is the normal one, and we could see that the soft tissue here is swelling. So this is the pyogenic arthritis, and is in the middle stage of the disease. We could find narrowing of the joint space and the soft tissue swelling. If we take the MR, we could find the destruction of the articular cartilage. This is another patient, and we could find here is the soft tissue. Here is the soft tissue is swelling, and the here is the destruction of the joint. Here is the destruction of the joint, and the joint space narrow. Joint space narrow. So we could find these three pathology. So this is the pyogenic arthritis. Here is another case, and the lesion is in the right hip joint, and we could find in the films the joint space is narrow. The joint space is narrow, and we could see in the head of the femur there's bone destruction lesions. So this the destruction of the articular cartilage. Destruction of articular cartilage. It will shows narrow of the joint space in the film because the cartilage is invisible in the X-ray. So it just shows narrow. It just shows the narrowing of the joint space. So this is the pyogenic arthritis. In the later stage, dislocation and subluxation result from the destruction of the joint capsule, and the periarticular calcification sometimes appears several weeks after onset of the infection. Bony ankylosis ensures if the articular cartilage is entirely destroyed. Pyogenic arthritis. In the later stage, we could find bony ankylosis in it. This is the ankle joint, and the joint space disappear. And we could find the bony tuberculations across the ankle joint, and here is the bony tuberculations across the joint space. So this we call it bony ankylosis. This is the later stage in the pyogenic arthritis. We could find bony ankylosis in it. And here is the wrist joint, and we could find that in the joint space disappear. The joint space disappear, and we could find the tuberculations across the joint space. So we call it bony ankylosis. And this bony ankylosis does happen in the later stage of the pyogenic arthritis. Next, we will learn about the tuberculosis of the bones. The tuberculosis of the bones and joints are almost always secondary to tuberculosis elsewhere in the body, especially pulmonary. Just as the other hematogenous infection of the bone, the initial focus usually starts in the metaphysis. First, we will learn about the tuberculosis of long bones. The classic location of the long bone infection is in the metaphysis or epiphysis. Unlike pyogenic osteomyelitis, there is less likely to be periosteal reaction, bone sclerosis, or formation of a sequestrum, although occasionally small sand-like sequestrum may be noted. The extreme appearance 1. Focal bone destruction by a well outline mimicking a broadized abscess or benign tumor. Small sand-like sequestrum may be noted in it and without bone sclerosis. Focal bone destruction. And there may be small sand-like sequestrum in it and without bone sclerosis. 2. It may have an aggressive permitted pattern, identical to a round cell tumor, even sarcoma, lymphoma, leukemia. And we will see some cases. This is the tuberculosis of the radius, and we could see in the distal part of the radius there is focal bone destruction in it. And in these films, we could not find any calcified lesions and sclerosis lesions. This is tuberculosis of the bones. And here is the we could find in the distal part. In the phalanges, we could find the focal bone destruction, and here is periosteal reaction. The soft tissue here is swelling. Density is decreased. So here is the tuberculosis of bones. As this disease progresses, it has a tendency to break through the epiphysis to involve the joint. It may break through the cortex, periosteum, and invade the surrounding soft tissue, forming a fistula. CT and MRI may be useful to guide the biopsy and can earlier offer as the location. extent of involvement, and pattern of destruction which are established by conventional radiography. Tuberculosis of spine. The spine has been the most frequent site of skeletal tuberculosis, and the disease is most prevalent in children and young adults. Common occurrence in such order: lumbar, cervical-lumbar region, and cervical spine. Coccyx is the least affected. Initial focus usually lies in the vertebral body, while the neural arches are seldom involved. Extreme appearance of the spine tuberculosis. 1. Destruction of the vertebral body or bodies and gives a wedge-shaped appearance. 2. Narrowing or total obliteration of the disc space between the two affected vertebrae. This feature is different and distinguished from those of fracture of spine or metastatic tumor of spine. X-ray appearance. 3. Core abscess formation. The paravertebral soft tissue shadow is broad, widened, and bulges to a fusiform swelling. The soft tissue swelling may be in the Fuchs muscle. 4. The destructive process causes a local kyphosis and scoliosis of the spine. We will see some cases. Here is the tuberculosis of the spine, and this view we could find in the thoracic and the lumbar region. We could find the surrounding soft tissue swelling. So this we call it core abscess. Here we could find the vertebrae is wedge shape. And destruction. Here is the destruction of the vertebrae. And this is after internal fixation. This is the X-ray films of the tuberculosis of spine. And here is the CT sagittal view. And we could find in the destruction. Here is the destruction of bone. In the destruction of bone, we could find the sand-like sequestrum. Here is the sequestrum in it, and the disc, the space is narrow. Here is the sagittal view, and this is the you could find in the destruction region. There is sequestrum in it. The disc space. Here is the disc space. The disc space between the two affected vertebrae. Between the two affected vertebrae. These two vertebrae, the disc space is narrow. So this is different from the fracture of spine and the metastatic tumor of spine. The surrounding soft tissue here is swelling, and we could see the abscess in it. So this is the cold abscess. And here is another case, and we could see destruction in the vertebrae, and there is sand-like circumstance in the destruction region. So here we call it circumstance, and the circumstance is sand-like. And here is the disk space. The disk space is narrow. So this is the actual view, and we could find here is the destruction region, and in it there is sand-like circumstance. And here is the surrounding soft tissue, and we could find here is swelling, and this is the abscess formation. We call it cold abscess. Here is the MRI of the spine actual view, and we could find here is the cold abscess. It's high signal in the T2 weighted imaging. Here is the cold abscess, high hyper signal, and we could find it more clearly than the CT. And this is a MRI, and here is the T1 weight image. This is the T2 weight image, and we could find that here is the cold abscess. Here is the cold abscess. And the disk space is narrow, and the disk space is narrow. Here is the normal disk space, and here is the lesion. Is just between the two vertebrae affected. So this the disk space is narrow, and here is the cold abscess. In the MRI, this lesion is more clearly than CT and X-ray. Intervertebral disc herniation. The intervertebral disc herniation occurs most commonly in the second to the fourth decade of life. The lower lumbar intervertebral discs are affected most frequently, and the cervical in the next place. Clinic manifestation. Posterolateral lumbar disc herniation typically compress the adjacent nerve root in the lateral recess of the spinal canal or in the intervertebral foramen, with the resultant pain, paresthesias, numbness, muscle weakness, and diminished reflexes in a radicular distribution characteristic of the nerve root being compressed. Brain fields are relatively insensitive for detection of early structural change in bone, and CT has been the most widely accepted initial examination for the diagnosis of a lumbar herniated disc. MRI has been the best way to diagnose the intervertebral disc herniation in all spines. The diagnosis by CT: 1. Focal extension of disc density into the spinal canal. 2. Displacement of the extradural fat at the site of herniation by the protruding mass. 3. focal deformity of the anterolateral margin of the fecal sac by the impinging mass. 4. Displacement of the emerging or descending or exiting nerve root by the impinging mass. And here is the CT. This is the MRI. These two are MRI, and here is the CT. And here shows the normal intervertebral. MRI is the best way to diagnose the intervertebral disc herniation. The center, here is the center nucleus is surrounding by the peripheral annulus. Here is the peripheral annulus. Fibrosis, hypointense. And here is the nucleus is hypointense. Here is the spinal canal. And if the nuclear materials herniate into the fissure and compress the things hereabout and gives rise to signs and symptoms. And if in the spinal, the nucleus protruding in the spinal canal and compress the nerve root, and it will have the symptom for the compressing. So this the tissue in the MRI is very clear. Here is the nerve root, and here is the spinal canal. So this shows the normal, and the disc is in it and hyper intense. Here is a CT of actual view, and here is the spinal canal, and the disc is in the vertebrae, and the shape is like the vertebrae, and didn't out of the vertebrae. And if the nucleus protruding out of the peripheral nucleus fibrosis and protruding into the spine canal, and it will press the spinal nerve. And here is the nucleus and protruding in the spinal canal. And here is the nucleus protruding into the spinal canal. And here is normal. Here is the normal. And here in the actual view, and we could see that the nucleus protruding to the spinal canal. And CT, this is CT. Here shows the intervertebral disc herniation, and here is the high density, high density in the spinal canal, and the nucleus protruding in it and compress the nerve here. Here is the nerve, and here the nerve is compressed by the nucleus. And here is the sagittal view. And this is the normal. And here is the nucleus protruding in the spinal canal and compress the root, the nerve root here. So this is the CT, shows intervertebral disc herniation. And here is the MRI, shows intervertebral disc herniation. And here is the normal intervertebral disc. Here is the normal, and here the central nucleus protruding in the spine. Here is also the nucleus, the central nucleus protruding in the spinal canal. And here shows the nerve root. The central nucleus compress the nerve root here. Here is the nerve root. And here the central nucleus compress the nerve root. And here is the normal. Here is normal. Here is the lesion. So MRI is very clear to show the tissues. And next, we will learn about the tumors. Bone tumors. Radiologically, the diagnosis of the bone tumors should include 1. Whether the bone lesion is tumor. 2. Whether the tumor is benign or malignant, primary or metastatic. 3. Which kind of the tumor is according to the histologic types. 4. An assessment of the circumstances of the bone and soft tissue are affected. So we learn about the differentiation of benign tumors from the malignant. Here is the benign tumors and here is the malignant. And in the development, the benign tumor is grows slowly, not a joining tissue extension or only displacement by pressure. But in the malignant, it grows rapidly, and the adjoining tissue or organs extensions commonly. The metastasis in the benign tumor, there's no metastasis, but in the malignant tumor, there is metastasis may happen. Local bone changes in the benign tumor. The local bone changes is expanded lesion with well-defined and sharp endosteal margin. Cortex thin and expanded with continuity. But in the malignant tumor, the permitting destruction pattern with ill-defined margin and wide zone of transition. Adjacent cortex frequently destroy. Tumor bone formation. The reactive periosteum bone. In the benign tumor, the periosteum reaction absent or present after pathologic fracture without destruction. In the malignant tumor, the periosteal reaction shows variousness frequently with destruction. And adjoining soft tissue changes. In the benign tumor, the soft tissue absence or mass with well-defined margin. But in the malignant tumor, the soft tissue shows permitting soft tissue mass with ill-defined margin. So this is the differentiation between the benign tumor and the malignant tumor. First, we will learn about the benign tumors. Giant cell tumor. Giant cell tumor is a local aggressive neoplasm composed of connective tissue and multinucleated giant cells that resemble osteoclast scattered in a matrix of spindle stromal cells. So it is also called osteoclastoma. It may be benign, malignant, and transitional. The clinic manifestation, the age in incidence of these tumors is most from 20 to 40. This is important, the age. The signs affected most frequently are the long tubular bone. That's most frequently happen in the long bone. Bones about the knee, the lower end of the radius, spine, and innominate bone in a skeletal mature patient. The symptoms: 1. Pain of increasing intensity. 2. Limitation of motion of the adjacent joint. 3. A pathologic fracture was occasionally the first symptom. X-ray appearance: 1. Obscurated lesion in the end of a long bone and in or adjacent to the metaphyseal region. It may expand to the subchondral bone and abuts on the joint surface. 2. Soap bubbling appearance with scanty tubercularity. A delicate tubercular pattern results from the sequential cortical thinning and expansion. Violation of the cortical surface and spread into contiguous soft tissue is striking evidence of the aggressiveness or the malignancy of some giant cell tumors. We will see some cases. Here is a case of giant cell tumor of the proximal radius, and in the film we could find obscurated lesions adjacent to the metaphyseal region. Here is the metaphyseal region and obscurated lesions adjacent to it, and the lesion shows soap bubbling. So we could make a diagnosis of giant cell tumor. The CT scanning may provide precise signs of the tumor mass, its location and relationship to muscle bundles and facial planes, definition of the markings of the tumor, and the relation to neural, vascular, and adjoining bony structures. They may appear cysts or fluid-to-fluid levels in the solid soft mass on the CT images. After contrast medium administration, the tumor can enhance its sepsis. Here's another case of giant cell tumor. and we could find the lesions is in the distal part. In the distal part of the radius, and we could see the uh, soap bubbling appearance, and with scanty tuberculations. The soft tissue is normal in the films. So this is the typical symptom, a typical uh, appearance in X-ray. That is so bubbling appearance. So this is uh, in the tibia, in the distal part of the tibia, and it's just expand to the subchondral bone and about on the joint surface, and it also shows soap bubbling appearance and obscurated lesion adjacent to the metaphyseal region of the long bone. So this is the giant cell tumor. And here is the in the distal part of the femur, and we could see the local destruction, and the destruction is so bubbling appearance. The surrounding tissue is normal. So this is the giant cell tumor. And here is the CT. Here is the sexual view, and this is the uh, actual view. This is the coronal view. And we could find the local destruction region, but in it we could not find the cell bubbling. Sometimes some cases will show will don't show the uh, cell bubbling appearance, but the region is just happen in the distal part and adjacent to the metaphyseal region, and the age is from 20 to 40. So we could make the diagnosis. For cyst, there was a great preponderance of young children, especially in the first 2 decades of life. It was preponderance of the humerus, particularly the upper metaphysis. The next most common site was the upper end of the femur. It may be discovered because of a fracture or incidentally after an X-ray examination for other reasons. A small cyst can disappear through osteocartilaginous callus formation after the fracture, and a large cyst may get small as well after this. X-ray appearance: a well-outlined radiolucent metaphyseal lesion, usually located centrally, expanding and thinning the cortex. 2. The cyst has its broader base and greater diameter near the epiphyseal plate and its conic end in the shaft. 3. As the long bone grows, the cyst moves away from the epiphyseal plate and is found in the shaft at variable distances. 4. The bone cortex is thin but never completely destroyed without periosteal reaction. CT scan shows a focal unilocular area of waterline attenuation with the well-magneted wall in the affected bone. After contrast median administration in harm CT, the attenuation in the cyst remains unenhanced. We will see some cases. This is the bone cyst, and we could see the well-outlined bone destruction region, and the cortex become thin and without periosteal reaction. We could not. Here is the cortex, and outside the cortex, we could not find the periosteal reaction, and the cortex is thin, and the lesion is well outlined, and destruction, the bone destruction. So this is the bone cyst. The most important complication is a pathologic fracture. The bone cyst, and we could find the fracture. Here is the translucent line, and the cortex is discontinued. So we call it pathologic fracture because the fracture is happen in the diseased bone. So we call it pathologic fracture. Malignant bone tumors. We will learn two malignant bone tumors. One is osteosarcoma. It is the most common type of primary malignant bone tumors, and it's a disease of young adults. About 80% of the tumor appears before the age of 30. Males are twice as common as females. Osteosarcoma usually arise in the metaphysis of a long bone, more frequently at the distal end of the femur, the proximal end of the tibia, or the humerus. It includes three types: osteoblastic type, osteolytic type, and admixture. The osteoblastic type is very dense and structureless. There is very high density. And the osteolytic type is various degree of destruction. And the mixture is both of the above coexist. The X-ray appearance. 1. Tumors with abundant tumorous bone or tumor osteoid matrix may reveal a dense tumor bone radiologically. There is very high density in the X-ray. 2. A tumor in which tumor bone formation is sparse appears largely osteolytic. 3. The periosteum is highly irregular. Sunburst appearance dense radiating bone speculations. Common triangle near the edge of the mass may be seen. Here, this too is the periosteum. And 4. The soft tissue mass immediately adjacent to the affected bone may be detected, and tumor bone formation may occur in it. Common triangle. This phenomenon is considered to be due to direct erosion of the already formed periobsteal new bone by fast-growing tumor. The common triangle is not just happen in the it's not just happen in the sarcoma, the osteosarcoma, but also happen in other um, malignant tumors because it just is just formed periobsteal new bone by fast-growing tumor. So it will happen in another malignant tumors. MRI appears to be superior to the plain field and CT scanning in defining the intraosseous and extraosseous extent of tumor. Therefore, MRI is able to show the osteosarcoma earliest when the tumor only infiltrates in the marrow and the tubercle are not destroyed. The MRI could find the lesions more earlier than the CT. Osteosarcoma. This is the admixture type, and we could find the here is the tumor bone. Here is the tumor bone, and you define obvious sclerosis with mass extending into the soft tissue. Here's the tumor bone. And here we could find the destruction of bone. So this is the mixture type. Both destruction of bone and the tumor bone. Here is the osteoblastic type. We could find the tumor bone. The tumor bone is very high density. So it happened in the distal part of the femur. This is the osteolytic type, and we could find the tumor bone formation is spare, and we just find the destruction of the bone. So this is the osteolytic type, and here is the osteoblastic type, and we could find bone destruction, and here is the soft tissue. There's a mass formation, and here is the vessels of the mass, the tumor mass. Two, we will learn about the metastatic bone tumor. Carcinoma elsewhere in the body may show distant metastasis to bone through blood stream or lymphocytes. It is common from the breast, thyroid, lung, kidney, or prostate, but rarely from the gastrointestinal way. The vertebrae, pelvis, ribs, and skull are often the sites of the metastasis. Lesions are usually multiple, but it may show only osteoporosis on the film. The tumor types, osteolytic type. In the osteolytic type, It will be irregular, radial, loosened patches of bone destruction. That's we could find the bone destruction in the films. When the vertebral column is involved, the lesions are frequently multiple and jumping. Both the body and the pedicle may be destroyed. The vertebral body becomes compressed and assumes a wedge shape, but the intervertebral disc space remains intact. We will see some cases. Osteoblastic type, less common type and usually represent a slow-growing tumor. It is usual with prostatic. It shows increase of bone density on the film with loss of normal bone architecture. Admixture type is both the above coexist. CT and MRI has been used most intensively in the evaluation of spinal metastasis. They may show the extent of the metastatic lesions. Metastasis occurs often in elderly persons and in the bones rich of red marrow. The vertebrae, pelvis, wrist, and skull are often the sites of the metastasis. And metastasis bone tumor. This is the obstetric type, and we could find the bone destruction. Both the body and the pedicle may be destroyed. And here we could find the destruction of the bone, the body, the vertebrae body, and the pedicle um, are destroyed. And metastatic bone tumor. This is the obstetric type, and we could find destruction bone, in the vertebrae, and the vertebrae become wedge shape. And here is the pedicle, and the vertebrae may be destroyed. But in the films, we may not see the lesions, but in CT, the lesions is easily to be found. And this is the osteoblastic type, and we could see high density in it. So this is the metastatic bone tumor, osteoblastic type. And here also is the osteoblastic type, and here is the sunburst type of the periosteal reaction. And this periosteal proliferation, reaction shows a malignant bone tumor. So this is the metastatic bone tumor. And here is the osteoblastic type, and here is the tumor bone formation. Here is the tumor bone formation, and the lesions are always multiple. And here is the lesions, high density, and here is the lesions, high density. And this is the metastatic in lesions in the spine, and the lesion is multiple and jumping, and the disc is well preserved. The disc space remains normal. So this is different from the tuberculosis of spine. In the tuberculosis of spine, uh, the vertebrae disc is narrow, but in the metastatic bone in the spine, the vertebrae disc is normal. Okay, our class is over. Thank you.